Good afternoon. My name is Vince Rock, Program Manager here at the American Brain Tumor Association. The ABTA is pleased to welcome you back to our webinar series. Today's webinar is titled Radiation Therapy for Brain Tumors. This webinar is sponsored by Accuray. Please note that all lines during our webinar today are muted. If you have a question you would like to ask, type and submit it using the question box in the control panel on the right-hand side of your screen. Our presenter will answer questions at the end of the presentation. The webinar will be recorded. The recording will be posted to the ABTA website on the webinars page within the next week. Registered participants will also receive the webinar recording link in a follow-up email message tomorrow. In the next few days, you will receive an email asking you to take a brief survey to evaluate the webinar. Please take a few minutes to share your feedback, which is important to us as we plan for future webinars. I'm delighted to introduce our speaker today. Dr. Lawrence Kleinberg has been responsible for radiotherapy care of patients with brain and spine tumors at Johns Hopkins and is an active clinical researcher. He did his medical training at Yale University and his residency at Sloan Kettering. He has been at Johns Hopkins University since that time. Thank you very much for joining us, Dr. Kleinberg. You may now begin your presentation.
Thank you for inviting me to give this presentation. It's a big part of what I do every day, educating my patients about radiation. And I know that some people in the audience may be going through radiation or may have a loved one or themselves completed their radiation and know most things from experience. But many people know that they have illnesses that may or may not require radiation treatment in the future. And that's something I also spend a lot of time doing in my clinical practice, seeing people just to educate them on what may lay ahead. Depending on the needs of for their care in the future. So it's a pleasure to be able to do this. I do have to disclose the research support that I get from several companies, some of them involved in producing things that are used for care of brain tumor. I do get support from Accuray, the sponsor of this webinar, and they produce one of the radiation machines, the CyberKnife robotic radiation machine, that I will be mentioning as one of the care options later. Novacure also makes a device used in the treatment of high-grade glioma, glioblastoma, and I'll briefly be mentioning that later. And I get support from another company that makes drug therapy for brain tumors, Arbor Pharmaceuticals. I'd like to cover several topics. One is, what is radiation? How does it work? And how is it given? I'd then like to talk specifically about how it can help with various types of brain tumors. And it's used in many situations, glioma or glioblastoma, or sometimes called astrocytoma. It's used for benign tumors like meningiomas or vestibular schwannomas. And it's used for spread of other tumors to the brain. When lung cancer or breast cancer, for example, when it spreads around the body, may land in the brain and start to grow there, and then that needs to be treated to improve long-term outcome. Many of my patients I see do, of course, look at the internet and hear about different radiation technologies and approaches. So I'm going to briefly give an overview of that because I know it's of interest to people. And then, if there's time, just a few brief words on ongoing research to improve radiotherapy treatment to give you ideas of where we're going, hope to go in the future. But first, what is radiation therapy treatment? And it really is an X-ray beam aimed at a tumor, not dissimilar to any other kind of X-ray you have, but it is more powerful. It has a higher energy and is therefore able to kill tumor cells as it goes through the body. It's produced by a machine that, and there are different brands, but they basically look like this. And it looks like a giant X-ray machine that rotates around and may point to people from different angles. people getting treated for brain tumors to help keep them still so that the aiming will be precise will often be wearing a custom-made mask like you see in this picture. Usually, most people don't find it that uncomfortable. I know it's easy for me to say, but it is a mesh that people can see through. And because the room around the person is open, even people who have a hard time with MRI scans often find that this isn't that difficult to go through. But medicines are available when it's hard for an individual person because of the anxiety that being closed in may cause. Radiation was first used to treat tumors in 1896, about 2 years after Madame Curie discovered radiation. Don't really know why someone got the idea of what would happen if radioactive material was held up to a tumor, but nevertheless it was done, and the tumor did shrink. And that was the beginning of the use of radiation to treat tumors. Of course, it was also learned that the radiation doesn't just shrink tumors, that it can have side effects. And this is something I always felt was interesting. This is a quote from Thomas Edison when he was trying out different ways of producing electronic light. And he used something that produced X-rays. And he discovered that his assistant who was working with it had his hair fall out and then developed these real bad skin burns. And so Thomas Edison concluded that it would not do and that it would not be a very popular kind of light. And so he dropped it. And so one of the big challenges in the next 120 years has been finding ways to best use radiation to control the tumor and minimize the chances of it having any of these ill effects that were described by Thomas Edison. And that gets into the next step. Well, how does radiation work? And even today, there's some uncertainty. And back when it was first used, no one had any idea how it worked. They just knew that it shrunk tumors. But it does seem that it does have most of its effect by damaging the genetic material, the DNA of tumor cells, so that the tumor cells will slowly die off because they don't function properly and can't divide and reproduce. It may also have an effect on the small blood vessels, the capillaries that supply blood to the tumor. And only recently have we learned that it may provide a basis for a greater immune response to the tumor. And that this effect we had no idea about for over 100 years may actually be important. And if we have a few moments to talk about research, I'll get into that a little bit. The advantages of radiation are that it's non-invasive. The radiation beam can get to deep areas of the brain without causing much injury, so areas where surgery can't be done are amenable to treatment with radiation. The immediate risks are usually not severe, although I will get into the side effects in a few moments. Radiation is not that pleasant to go through. But later on, most people would say it really wasn't that bad when it's all behind them. It can treat unseen tumor extensions that cannot be removed. And certain types of brain tumors, like glioblastoma, can have wisps that track into the nearby normal brain. And if that normal area brain was removed, it might lead to a lot of dysfunction. But radiation can be aimed at that area where we think the tumor may be hiding and has causing very little damage to the normal brain while treating the tumor within it. And we can treat areas that can't be removed surgically, again, because they may be deep in the brain or near important blood vessels where the surgeon can't take a chance on damaging that blood vessel and causing bleeding. But there are disadvantages to radiation. Certain types of tumors don't respond well, and only surgical removal is effective. Radiation does not immediately remove a mass. When someone has surgery to remove a tumor, it's gone, and the pressure on the surrounding brain can get better. In many cases, a lot of the symptoms can get better. But radiation may damage the tumor, may kill it, but it doesn't really shrink away very quickly. And so the person may not get better even when radiation has worked. It's also not very effective for very big tumors, and surgery is really much more effective when there's a very big tumor. Radiation does have side effects, and an important thing to know is although the immediate risks may be a lot less, the risks do hang over the person well into the future. So whereas in general, if someone comes through their surgery and recovers well, they don't really have many worries ahead. But injuries from radiation can happen even over a few years after the treatment was given. And radiation, like surgery, is only good where we're targeting it. It doesn't treat the whole body. So for example, for metastatic cancer, tumors that are spreading around the body, radiation is just dealing with one part of the problem, but something is needed that will control the hidden tumors all over the body, and that's chemotherapy or the new targeted drugs or immune therapy. The side effects of radiation, and I know many people in the audience may have been through it, are related to where the beam is aimed. So the side effects of brain radiation are different than the side effects that may happen with treatment in other parts of the body. And it's important for people to know this. I often get questions from people because friends or relatives have had side effects from radiation, for example, severe nausea or diarrhea or shortness of breath. But that's because the radiation was aimed at different parts of the body. For example, radiation to the stomach may cause powerful nausea. When the brain is treated, the common side effects are fatigue, and that can really bother people, just a feeling of being tired that builds up as the weeks of radiation goes by, then gets better in the weeks afterwards. Brain swelling or irritation of the brain that may cause symptoms is also a relatively frequent side effect. It does tend to be similar to the symptoms that the brain tumor itself was causing because that's the area of the brain where the radiation is aimed. And I always warn people that their symptoms may temporarily get worse. And I like to warn people because it would be normal to panic, to think the tumor must be growing back. But it's rare for tumors to actually grow during radiation, and swelling or irritation of the brain is quite common. So when something's getting worse during the radiation or right afterwards, it usually is a temporary side effect of the radiation. These side effects can often be improved with steroids or dexamethasone medication, but these medicines are not well liked by our patients. And so often people will decide that they'd rather wait for the side effects to eventually go away if they're mild and not really severely impacting them than going on steroid medicine. That's always a discussion when the side effects from radiation develop, whether it's worthwhile for an individual patient to start taking steroid medicine or not. Importantly, there are some long-term risks. If you add up all the really bad things that can happen, they don't happen very often, maybe to close to 1 in 20 or 5% of people. This could be permanent memory problems or cognitive problems that impact normal life, a new disability because of injury to the brain. Sometimes there can be such inflammation from the dead tumor or tissue after the radiation that surgery is needed to remove this because it's just getting worse or worse. And unless that dead area is removed, the cycle of inflammation keeps building on itself. And another thing I always want to warn my patients about is that the effects of radiation in the short and long term, swelling resulting from radiation killing the tumor, can look like a growing tumor. And sometimes that causes a lot of stress because we person may get an MRI report that says things look worse, and then we counsel the individual patient that this really may be an effect of radiation, and we're going to keep monitoring it. And very often, this will then get better. But it does result in certainly stress while waiting for the follow-up MRIs. And I always try to warn people in advance so that if it does happen to them, they can feel more comfortable that this is a normal part of the process. This is an example, just not going to run through it, but put in there for reference for people having the slide set. This is the standard permission form listing most of the possible side effects from radiation that I use in my practice, and then I modify it for individual patients depending on their circumstances and where in the brain the tumor is. Now, there are these side effects, but radiation works because it injures tumor more than it injures normal tissues. Normal tissues and structures in the brain are better able to recover from any damage that the radiation does. The same things that make the tumor grow in a disordered fashion also make it unable to repair the damage from radiation. We learned, probably starting from trial and error in the 1940s or 1950s, that dividing radiation into small daily doses better protects normal tissues, whereas tumor does not repair those small bits of daily damage. That's why when a tumor tracks into the normal brain, and we're actually on purpose treating areas of normal brain where the tumor may be hiding, that's why the treatment drags on, often for 6 weeks, because giving it little by little is what can make it safe. The other way we've gotten better at making radiation safe is targeting it better, finding ways to make it more precise so it protects areas of brain that don't need to be exposed to high doses of radiation. The technologies that you may hear about for this better targeting for aiming the radiation are 3D treatment planning, intensity-modulated radiation, a precision radiation technique, radiosurgery, and now proton radiotherapy, which is recently becoming more available around the country. Originally, radiation would be aimed quite crudely. There wasn't even good scanning available, so the slide I have up is really an optimistic look. Even before my time doing it, the people who taught me said that it would often be that the surgeon would be pointing to the area of the skull where they thought the tumor was hidden underneath, and then a big radiation beam would be aimed at that area. But then, oh, sorry, my slide's not there. Then we got the ability to aim based on scans and to shape the beams from every direction to the exact shape of the tumor as seen from that direction. And this is called three-dimensional planning. You can sort of picture it like you could shape a flashlight beam or a spotlight to project a rabbit on the wall. We got the ability to make a three-dimensional picture of the tumor and the normal parts of the brain and head that we'd like to shield. Then from every direction, we could shape the beam to match what that looks like from any individual direction where we're aiming it. We would also be aiming the radiation beams now from a lot of different directions. So every beam going through a normal area of the brain is weak, and only where these beams all meet or cross would the full amount of radiation be given, as if you had weak spotlights, and only where they all met would things be bright. The next thing to be developed was intensity-modulated radiation. This got a little more complex. It's not just the shape of the beam in 3 dimensions, but we're able to divide the model, computer model of the head that we make up into little boxes and see how much radiation each box will get to try to ensure that the tumor gets as much as it should and no normal area gets too much. And to make this puzzle of fitting these beams together work, we're now able to adjust the beam so that parts of it may be a little hotter, a little more radiation, and parts of it may be what we call cooler. So you can see on the screen that it's not just the shape anymore, but we can make, with little rods that go in and out of the beam, we can make parts of that shape give more radiation and parts less, to solve the puzzle of all these beams interacting to make sure that the radiation dose is optimal to tumor in both normal structures. And this gets so complicated now that no person can look at that machine and say, yes, our calculations are good, this is correct. And so at least the day before we start treating someone with radiation, we run the machine with an X-ray film model of the head, and then a physicist will analyze the special X-ray film to make sure that the radiation is being deposited in the way it's supposed to. Because there are lead rods moving in and out of the machine very quickly to block part of the radiation dose or intensify part of the radiation dose. And so it's important to do this double check to make sure that it is working the way it's supposed to. And a lot of effort goes into quality assurance to make sure that the person is getting the treatment that they're supposed to. And so, for example, with intensity-modulated radiation, we can make very complex shapes. And here, we're trying to shield someone's eyes. The circles right here are their eyes, and treat a tumor that's right between the eyes. And we were able to do that using this kind of technique. And so it really improved our ability to treat tumors in critical areas of the brain. Now you may hear a lot, and patients often ask, about proton radiotherapy, and discussing that might be a whole webinar in and of itself. But really, what proton radiation therapy is a beam that does not completely penetrate the brain. X-rays go all the way through and get absorbed as they're going through. So here you see a typical X-ray radiation plan with the tumor being treated quite well, but areas of the brain distant from the tumor are getting exposed to low doses of radiation. Probably this doesn't cause much damage, but in some cases it might. Proton radiotherapy, because the beams will go through and then stop, gives less radiation to distant areas of the brain. Proton radiotherapy, though, has had some other drawbacks. The radiation given to the area of the tumor may have irregularities or peaks of intensity, and it's very, very vulnerable to slight changes in the person's positioning day to day that may cause the radiation not to be delivered as planned. So that the early studies using proton radiation therapy for the most common type of brain tumor, glioblastoma, showed higher rates of injury within the area that was being treated on purpose. However, that technology was a much older version, and probably today it's not going to be the case. But studies are going on now comparing IMRT, the currently available X-ray radiation technology, to proton radiation, different than X-ray beams because it doesn't penetrate fully through, to see how that all works out and to try to determine in what situations proton radiation may be better and what situations it may not be better. Again, the standard fractionated radiation is usually 30 visits over 6 weeks, used for tumors that infiltrate into the normal brain, again, because that's how we protect the normal brain, giving it little by little. And this is optimal for large tumors where large areas of the brain may be exposed. Also for even smaller tumors that may have tracking into normal working brain that can't be removed because that part of the brain, even though there's a tumor that may have tracked into it, is still working well and doing important things for the person. The type of tumors that tend to do this, that infiltrate, are glioblastoma, anaplastic astrocytoma, low-grade glioma or astrocytoma, or another low-grade type of tumor, oligodendroglioma. Also, even a small tumor that is well confined, that's near the optic nerves or optic chiasm, the nerves that carry light perception or vision, need to be treated with radiation given over 5 to 6 weeks. These nerves, perhaps because the function resolving light is so very subtle, so very complicated, these nerves are very easily injured by radiation. But giving the radiation over 5 to 6 weeks does keep radiation safe for those nerves, whereas big bursts of radiation can often injure those nerves. And the types of tumors that tend to be near those nerves that are otherwise not otherwise well confined are meningioma, pituitary adenoma, craniopharyngioma, and certain other benign tumors that can occur near those nerves. And sometimes metastatic cancer that spreads to the brain can be in that location. And this often will lead to the obvious question that I might get from a patient who might have been told, you have a meningioma. That can be treated with often 1 day of radiation, a big burst. And then obviously it's disappointing when we have to have the discussion. That may be true in many cases, but your meningioma is near this critical nerve. And although it's much more inconvenient to get 6 weeks of treatment, it's not worth taking any risk to vision. And I bring this up again because people are often referred by someone who has diagnosed the tumor but has less of a knowledge of radiation and may not have been in tune as to why in some situations the radiation needs to be given in this drawn-out way, and not because the tumor is worse, but just because of where it is. To keep it safe, it needs to be given little by little. I'd like to show an example of glioma or glioblastoma. This is a tumor that the most common primary brain tumor, and it arises in the brain. This is the person when the tumor was discovered. Afterwards, the tumor is completely gone. This little white stuff left is really some blood, which also shows up white on an MRI scan, and we have ways of being sure that it's blood and not tumor. And so right after surgery, there's always a little bit of blood there. But we know that even if every bit of this tumor that can be seen is removed, that there's still wisps of it that are always tracking into the nearby normal brain. And we know from years of study where that's likely to be. So a radiation plan was made to treat this person, to target that area. And with the combination of surgery removing the bulk of the tumor and radiation removing the parts of the tumor that may be hidden or in some cases may be in such a critical area of the brain that they can't be safely removed, well, this combination of removing as much as can safely remove and radiation given afterwards results in an improved outcome as time goes by. In the next few slides, I was going to talk about specific things about the outcome for glioblastoma. This would be the next 3 slides. It will be no more than 1.5 to 2 minutes. Now, I'm not going to say anything specific about the outcome. That will be vague. So if some of you didn't want to see the exact statistics, but wanted to listen in, again, I won't be giving any precise information in what I say, but people looking at the slides will see it. It's also important to always keep in mind that none of this tells us what's going to happen with an individual person. These are just averages or medians, what happens to the middle person, and some people do much better than the average, and unfortunately, some people do worse than the average. Now I'm going to go to these slides. When radiation was first used for glioblastoma, people wondered, is this really worthwhile? It's 6 weeks, and this was in the 1950s, early 1960s, causes a lot of fatigue. And back then, because we couldn't aim precisely, the whole brain was treated, so all the side effects were worse. And people wondered, is this really useful? But we found that the group who got radiation, group C and D, in the large study that was done, did a lot better than the group that did not get radiation, groups A and B. So it became the standard thing to do because it improved the outcome for most people. Still, the outcome wasn't as good as you would want. And so a lot of studies were done to further try to improve the outcome. And a lot of those studies focused on adding chemotherapy, and the one that worked was temozolomide. And temozolomide really improved the chances of relatively long-term survival. So that's why this is added. Radiation is the mainstay of treatment. Temozolomide by itself doesn't help most people, but when combined with radiation, increase the chances of a good outcome years later. And another new thing that was tested in a large research study was this applicator worn on the head that gives electric fields administered to the area where the tumor is. This further, in a large study where people were assigned half to get it and half the patients not to get it, further improved the long-term survival beyond the effects of radiation with temozolomide chemotherapy. This is something that is new and was again studied in a large study and is now going to be tested in other tumor types to further confirm its effectiveness. But patients have feelings about this because it involves wearing this pretty much all day, every day, with some opportunities to take it off. And so people balance the effort involved in wearing that with the long-term survival benefit. Now I'd like to move on to a different situation, tumors treated with stereotactic radiosurgery, usually 1 to 5 precision intense treatments. Differs from prolonged fractionated radiation because it's very focused, a high dose to a small area. Because it's precise, we can protect normal tissues and give these very effective, intense bursts of radiation all at once. But to do that, we have to know exactly where the tumor is. It has to be a sharply defined tumor that doesn't infiltrate or track into normal brain. So we know where the tumor is, and we know we're not hitting much normal working brain. This can be very effective because it's very intense. It's often used for brain metastasis or spread of cancer to the brain because this pushes the tumor out of the way. Meningioma also tends not to erode into the brain, but push it out of the brain. And commonly acoustic neuroma, vestibular schwannoma, or pituitary adenoma. There are a variety of ways to give the precision treatment. That's me in the middle of this picture, years ago though. The gamma knife is one technology to do that, that keeps the person still, sometimes with a frame that's invasive screwed onto the skull to keep the person very still, or sometimes just clamped very tightly on, because tight positioning is very important in maintaining aim. The technology we use now, that we happen to have now, is the CyberKnife, and there are also other versions of this using linear accelerators, all that can give precision radiation. I've tried to put a video in, and never in my whole career have I had a video work well. And this is the first time ever that I've gotten a video to work in a slide. And the CyberKnife tracks onto a person's positioning. It's a robotic machine, and then moves around and aims from multiple directions, these very many weak beams all converging on that spot. And all these approaches are good ways to do it, really depending on what's available at the center where the person is being treated. But this is an example of a meningioma, giving this very, very precise burst of radiation. So this tumor can be treated in just one day with very little radiation given in these concentric circles to the normal brain. It's also commonly used in the treatment of brain metastasis. Whole brain radiation used to be done until the mid-2000s for everyone. It was all we really could do. We couldn't aim precisely, but in the in the early 2000s, people started to study using focused radiation because the whole brain treatment was unpopular among patients, caused a lot of fatigue, wasn't safe to give with most chemotherapy drugs that people needed to treat the tumor around the body, and had a real risk of causing memory problems 6 months, a year and a half later. So people wanted us to try the focused radiation to see if that would really work and whether it would result in better quality of life. We worried whether that would work, as we thought if there are a few spots in the brain, there are probably many others, and this might be futile. But as it turns out, that's not the case. 4 very large studies were done around the world showing that treating the tumor with stereotactic treatment when there's just a few spots in the brain resulted in just as good outcome in terms of the important thing, survival, as treating the whole brain. But that quality of life was better if just the individual spots are treated. This is an example, more and more now, that even people with tumors that have spread to the brain can do well for many, many years. This is one example of a woman who, when her tumor was discovered in 2013, had 3 spots in the brain, which we treated that way. However, in 2015, 2 more spots developed, and she was completely fine, functioning, doing her normal work and all her normal activities. So those 2 spots got treated. And then in 2015, 8 more spots were treated, and you would think that that means things are getting out of control. But then she did well for another 2 years in the brain, and 2 more spots were treated then. Unfortunately, in 2018, for this individual person, 5 years later, the chemotherapy was no longer working at stopping the tumor throughout the body, and things just progressed everywhere, unfortunately. But this is more and more common now that we treat individual spots in the brain, and that there are drugs that work around the body, that people do well. And because most chemotherapy drugs and most targeted drugs don't work in the brain, we find that people, as years go by, often need their brain treated several times. And again, I spend a lot of time counseling people that just because a new spot appeared in the brain doesn't mean that their tumor's now spreading again, getting out of control. It's just because it was likely there the whole time, just too small to see, and that the drugs that they were getting, stopping the tumor elsewhere in the body, were only partially effective in the brain. And then a new spot appears, and then we hit those new spots again. And now, we have we never know how things will turn out for an individual person, but there are so many people doing well now for many, many years, even though they need to have their brain treated several times along the way. After radiation treatments, it's usually easy to go through. You feel nothing when the radiation is given. It feels like getting an X-ray. But these side effects we mentioned build up slowly. they may come after the radiation. So I always warn people, don't assume new symptoms must mean that the tumor is growing. Even 6 months or a year later, this could be a temporary effect of the radiation, headaches or other neurologic symptoms related to the areas where the radiation was aimed. And that it's important, again, I know I mentioned this earlier, but I always emphasize again, because many people with the electronic medical record can actually read their own MRI reports before we have a chance to talk to them. I always want to emphasize that when they have a report that something looks worse, well, even 6 months, a year or more later, that could be a result of the radiation and not the tumor growing. So don't assume that a worsening scan always means that the tumor is growing. Now, in the last couple of minutes we have, just wanted to talk about the kind of things we're doing to try to make radiotherapy better. And it's always good in many of the situations to consider enrolling on a research study. No one should ever tell you you should enroll in a research study. It is experimental. If we knew that it worked, we would just all tell you this is what's best for you to do. But research studies can help people in the future and often give individual patients access to things that sound attractive to them, that sound like it may work and improve the outcome. But we are trying to combine radiation and immune drugs, combine radiation with different chemotherapy drugs. Important things are imaging studies to try to better find out, using different scan techniques, where the tumor is really hiding so we can aim the radiation better. And so that, and developing techniques that can better protect normal brain, which might be proton radiotherapy. And some studies are ongoing now to better define when proton therapy will lead to better outcomes in various brain tumors. One interesting research area, and I know the slide is busy, but this is a person who was getting one of the new immune drugs in one of the original research studies a decade ago for melanoma that had spread around the body. And it wasn't working so well. The tumor was slowly growing. But then they needed radiation and got the intense radiation for stereotactic radiation, a big burst for an area of tumor. And then not only did the tumor shrink where the radiation was aimed, but it shrunk everywhere in the body. And blood specimens were available on this research study, and they showed that the antibodies, the immune response to that individual's tumor, even though they had been on that drug for over a year, went up dramatically after the radiation was given. A simple way of looking at it was the radiation may have caused release of debris of the tumor, antigens, like what you get when you're vaccinated, that the immune system was able to detect. And then the immune system fought that tumor that it saw, everywhere in the body, that it was now able to recognize because it got exposed to that heavy load of tumor debris or antigens. And we followed up with this with studies in animals with glioblastoma, the most common primary brain tumor. And in these animals where the tumor was injected, we found that the combination of radiation and immune drugs did better than the radiation alone or the immune drug alone. And even moreover, in these animals at least, when the tumor was injected, re-injected, second time into the animals that did well, the tumors didn't take. Just like someone who's vaccinated against the flu, if they get exposed to that flu again, it doesn't take. Now, this is a long way to making this work in humans, but it is the kind of thing that may show great promise for improving outcome in humans. And then the final thing, another, and I'm showing research that I've been involved in, but there are so many exciting things going on. This is an potentially improved type of MRI that doesn't just look at the shape of the tumor in the brain, but looks at the chemicals. It's called spectroscopy, and this allows us to see if the chemicals are in the brain are normal or not. And there are some that have been identified with tumor. And we've been using this in studies to try to find where the tumor may be hiding. And with investigators at Emory University in Atlanta and the University of Miami in this study that's led by the team at Emory, we've tested whether guiding radiation using this may improve outcome. And now we're waiting to see the results to see whether larger studies should be done. But these are the kind of things that may make the outcome better. Again, localized tumor, again, radiation has several roles, treating areas that can't be removed because it's unsafe or where tumor can't be seen. It can treat limited areas of tumor when extensive normal brain doesn't require treatment. This can be very intense and often as effective as surgery without the experience of having to go through surgery. And in many situations, combining radiation with particular drugs can result in even better outcome because of a combined benefit. And I'd like to end by pointing out or giving a shout out to the American Brain Tumor Association educational materials that are available on the website. I was always aware of this, but because I was going to be giving this webinar, I looked at the publications and the educational materials available about radiation, and they're very good, as well as educational materials available about the variety of brain tumors that you may encounter. So I just wanted to point out that this is there, and then I guess we move on to questions now.
Thank you very much, Dr. Kleinberg. We will now take questions from our viewers. If you have a question you would like to ask, please type and submit it using the question box in the webinar control panel on the right-hand side of your screen. We will answer questions as time allows. So Dr. Kleinberg, our first question is about, it's really a two-part question. It's about radiation dosage and re-radiation. So as I understand it, and depending on the circumstances, there's a certain dosage that doctors will not want to go over for radiation because it might cause problems for the patient. But in certain cases also later on down the line, someone might have a recurrence and might need another course of radiation. So could you please speak to first of all, what the effects are of too much radiation, and then please talk about when re-radiation is appropriate.
Well, thank you. That's an excellent question, and I would have liked to have gotten into that in this talk, but there wasn't that much time, so I'm glad it came up as one of the questions. You can't see how old I am, but back when I was in training, we would have said it is much too dangerous to give radiation a second time. That radiation a second time might just completely damage whatever area of brain we're aiming it at. That, depending on the area of the brain, that could result in severe memory problems or on severe disability, unable to use an arm or a leg. But a large study was done, again, just over a decade ago in Germany with hundreds of patients where people with gliomas and glioblastomas were treated a second time, and it turned out to be fairly safe, not much riskier than the first time, and it tended to be able to control the tumor the second time. So now it's something in my practice I do offer to my patients quite frequently if they're in a position where the tumor is growing. It's always an individualized decision because a second course of radiation, like the first course, could injure the brain, and the risk is a little bit higher the second time. But when radiation has worked well the first time, it's become very attractive for my patients to do it again with the idea that, yeah, there's a risk, but hey, I got a lot of years out of the first time, and so it seems reasonable to do again. So now we think of it as something that can be done twice in the disease course of glioblastoma or other glioma tumors.
Thank you very much. We had another question about the late effects of radiation therapy. So these are side effects that may happen sometimes several years down the line after treatment. Could you speak a little bit about this and what some people experience with late effects?
Yes, and this was an important point that I alluded to in one of the earlier slides, that the risks of radiation can express themselves a long time later. And so it is something that, you might say can be a worry as years go by. And the typical effects that might happen later could be some cognitive or memory problems, often not so severe that they affect normal life or being able to work, but that the person themselves feels like, oh, things aren't as good, things are a little harder. And then cognitive counseling can help if that really bothers the person. Strategies to work around it can help. Occasionally, bad injuries can happen even years later, even years after the radiation. That could vary from bad cognitive problems or necrosis of the brain, death of an area of the brain, causing tremendous inflammation and disability. And rare, but a real risk in long-term survivors is the reason we try to avoid radiation in our day-to-day lives is that it could cause cancer, and certainly in long-term survivors after brain tumor, there is a risk of another cancer resulting from the radiation. Again, with this type of radiation, that is rare, but it can happen. And so I put them in two categories. I don't want to use the word minor long-term side effects because these things can do affect people, but things that don't interfere with normal life, like mild cognitive problems or some physical slowing that still allows people to do all of their normal things, and then the less common risk of some kind of severe or disabling injury. And those things, when you add them up, again, from severe memory problems to a new disability, it is less than 1 in 20 people, but not zero. It does happen.
Thank you. The next question has to do with minimizing side effects. You talked about some of the great technologies that we have now to focus radiation dosage and conform it to the tumor. Are there any other techniques or technologies or even emerging technologies you might have heard of that can help to prevent or reduce side effects?
Well, there are some interesting things being studied right now. Some of my colleagues are doing rigorous studies to try to define what areas of the brain, when injured, really cause memory problems. And if we could really identify where that comes from and how much radiation results in that kind of injury, we can then take steps to try to prevent that. I'm not sure I made sense the way I just explained that, but trying to figure out, figuring out what areas of the brain getting too much radiation results in those memory problems years later. And again, knowing that, we can try to protect those particular areas. That's a big area of research now. And then drugs are under study that may help protect normal brain. Some of them have had promising results, but I don't routinely use them for my patients yet because the follow-up information from those drugs has only been perhaps 4 months after the radiation treatment is given. And I always wonder if it results in some improvement in that period of time immediately after radiation. Is that just because people are still suffering from radiation fatigue, still suffering from the temporary side effects of radiation, and that these drugs are not really going to help with the long-term outcome? But these studies are going on now, and hopefully we'll learn a lot to make radiation even safer.
Thank you. We also had some questions about specific parts of the nervous system and what approaches might be taken when radiation is considered as a treatment option. So a few people asked about the brainstem, and one person asked about the cranial nerves. So what types of approaches are typically used for these parts of the brain when considering radiation treatment?
Yes, and this is a very good question, and it's a very complicated issue. And the concern about the brain stem and the cranial nerves is that any injury to these structures often causes symptoms that are quite disturbing, quite disabling. Uh, and so, the way we approach it is, if there is a couple of a percent risk of an injury to an area of the brain, and if that injury happens, the person's life will not really be affected that much. That sounds quite reasonable, when trying to control a tumor. But if the brainstem is injured, it could cause tremendous disabilities with motion of the eye, vision, balance, coordination, strength of different parts of the body. In extreme cases, it could even be fatal. And individual cranial nerves could affect vision, hearing, swallowing, things that again, if damaged, cause tremendous problems in normal life, tremendous impact on quality of life. Uh, and so the question in treating these areas we've settled on is just to be a little more cautious, that not to push the radiation to the dose where there might be a several percent risk of injury, but to try to make it just a little bit safer by cutting down on the amount of radiation a little bit and finding a balance between best chance of long-term control and best chance of not causing any immediate injury. And with this, we're able to keep radiation generally safe even for these critical areas. And I might use as an example for vestibular schwannoma, when radiosurgery, that intense radiation, was first used for it as an alternative to surgery. Surgery had a high risk of damaging open surgery, high risk of damaging the facial nerve, which if damaged causes a droop like a stroke might. So people were trying to look for ways to avoid that risk. And they thought that radiation might be successful at treating the tumor and avoiding that risk. But at the beginning, high doses of radiation were used. And although radiation was safer for this complication than open surgery, it still wasn't safe enough. And then the investigators at the University of Pittsburgh said, well, what happens if we use a lower dose of radiation? Will it still work? And will that complication go away? And they found that with a lower dose of radiation, long-term control of the tumor was still just as good, but the risk of any damage to the facial nerve, that is really a hated complication, became very, very low. And so all of these concerns are important with these critical areas of the brain. When push comes to shove, how much radiation do you really need to give? Is more really better? And what can we do to keep it safe?
That is all the time we have today for questions. Thank you all for joining us, and thanks once again very much to Dr. Kleinberg for his wonderful webinar presentation. Aside from our educational webinar series, thank you, Dr. Kleinberg. And just a couple announcements now. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. The ABTA National Conference brings together patients, caregivers, researchers, and medical professionals from around the country to network and gather up-to-date brain tumor information through first-class educational programming. Join us in person in Chicago, Illinois, or via our live streaming platform this September. For more information and to register, visit abta.org/national-conference. The ABTA also hosts regional patient and family meetings across the country. Check out our website to find a meeting near you at abta.org/regional-meetings. Would you like to get more involved with the ABTA and meet other brain tumor patients and caregivers? The ABTA's Breakthrough for Brain Tumors 5K run and walks currently take place in 10 cities throughout the United States. We are gearing up for our fall events and would love to see you there. Learn more by visiting bt5k.org. For more information about ABTA's programs, events, and services, visit our website at abta.org, email us at info@abta.org, or call the ABTA care line at 800-886-2282. This concludes our webinar. Thank you for joining us, and please be sure to complete the evaluation survey you will receive by email within the next 2 days. And thank you one more time to Dr. Kleinberg for a wonderful presentation. You may now disconnect.